Hi, my name is Paul Gerst of the Balanced Path Wellness Center. I'm a licensed acupuncturist of 21 years and a natural health practitioner. I'd like to welcome you all to Health Naturally, a show I'm doing to introduce Medway area practitioners and people in the health field. Today on the show we're going to have Dr. Mary Medeiros of Thrive Adult Primary Care. Mary, thanks for being on Health Naturally.
Thank you so much for having me, Paul.
I'd like to start out just by you sharing some of your personal journey with us.
Well, I was born in California, mostly grew up in New York. I'm of Filipino heritage, but I've never actually been there, sad to say. So I'm culturally American, and I I grew up in a pretty stable family with two psychiatrists as parents, so that kind of calls into question the stability in a different way.
There's a challenge.
But it was an interesting journey, and I was sort of groomed to be a doctor from the time I was young, which is common in Asian families.
Tell us about some of your, just kind of further that question a little bit, some of your personal or avocational interests.
Well, I think the things that I really love doing the most would be music and art, music in particular. As a matter of fact, when I was in college, I was trying to choose a path that was going to lead me towards medical school because I knew that was what I was supposed to do. And I wound up pursuing a bachelor's degree in music. I was a music major because I said to myself, this is the last time I'm going to get to do something that I love. Thinking that medicine was going to be sort of an obligatory path, but it shifted. I wound up in a place where I've actually come to love practicing medicine.
So what's your breadth of musical interest? What did you play?
Well, my medium of performance when I was in college was flute, but nowadays I like to sing and play the guitar, and I go to open mic when I have the chance.
That's right. And so you mentioned something to me when we were talking before the show about your art interests. So
I used to draw a lot when I was in high school, and I won a couple of awards when I was in high school for my drawings. But now I just do it for fun. I try to get my kids involved in it and stuff.
Well, okay. So what led you to a career in medicine?
Well, like I said, when I was a child, my parents are both physicians, and which is common in Asian families. If there's medicine in the family, they're going to sort of gear you towards it. And my dad, bless his heart, told me that I could, after I became a doctor, I could do whatever I wanted. And I wasn't really sure that was what I wanted to do, but I pursued it, and just sort of understanding that was my defined path. And
so in essence, become a doctor, and then you can go do whatever you want.
That was what he's told me. So it turns out it doesn't quite work out that way. Once you're on that track, you kind of have to stick with it. So that's the short version of how I got to be a doctor.
Quite the investment. Okay, so as far as your, what was your professional path that led you to go out on your own and open the business that you have now, which is Thrive?
It was not something that I would have anticipated from early on. I never saw myself as being like this adventurous lone wolf, business person. And certainly in medicine, we don't really think of ourselves as business people. We don't learn anything about business. So I started out finishing my training. I did training in internal medicine. Yeah. And after that, I did supplementary or sort of a fellowship training in preventive medicine with an emphasis on correctional health, meaning that I learned how to take care of prisoners. Wow. And it's funny, I like to say I did some time, but I spent some of my training actually caring for patients at MCI Norfolk and MCI Framingham, which was a really interesting journey. And my original thought was to become a medical director. That was one of my avenues of trying to take care of the underserved in a way. Mm-hmm. It's an underserved population, and my parents, both psychiatrists, were prison psychiatrists. So it was it was a fascinating pathway to me. But life led me in a different direction. I got married, and I was pregnant with my first child when I was finishing that training, and it was just so emotionally and just energy absorbing to take that path. I wanted to focus on my family, so I geared away from prison medicine and wound up becoming an assistant professor at UMass in hospital medicine, which I loved. So my life was like Scrubs. I get to round with the residents and students, and that was absolutely wonderful to me. Life shifted again, and we had to kind of relocate for my husband's job, and I wound up going into primary care, which I think I always wanted that to a certain degree because I love having longitudinal relationships with patients. So that I went into a sort of a corporate group practice model and started practicing primary care in 2014 on a regular basis. There was some primary care in the prison, and I'd done some urgent care in clinics before that. And that was a very eye-opening experience. I think it really reflected the state of primary care in the majority of situations, because honestly, group practice is probably the most widespread application of primary care right now. And I learned a lot, especially in the interest of trying to balance a family, and it was unsustainable. So I found myself trying to look for something else.
So how much, just to ask about the family issue, this is personal curiosity here. The challenge of raising a family and doing that, how is going into your own business different? How is that going to make that better?
Well, I mean, the thing is, it's when it's my practice, then I have control of it. But there's just vast differences in the way direct primary care operates compared to like a group practice setting.
Speaks to the challenges that a lot of doctors have working in that setting.
It's very widespread.
Yeah.
It's very common.
I gave a brief definition of direct primary care in the introduction, but will you give it again and what drew you to it?
Sure. Direct primary care, I often like to say, is a relationship between a patient and a doctor that is unencumbered by the increasing complications of third-party reimbursements like insurance or government programs like Medicare or Medicaid, Mass Health. So it eliminates that middleman, and directly between the patient and the doctor. There are costs involved with delivering health care. When those costs are shuttled through a middleman, then there's a lot of sort of complexities that go along with it that can influence the patient's access to the care. So in direct primary care, you go direct, you actually eliminate the middleman, and it's a patient who is investing directly into the practice through a monthly membership, which is affordable, compared to any of the other health care costs out there, if anybody could actually see them transparently. And just with that direct financial relationship, then the healthcare relationship becomes direct as well. I like to say that I'm no longer employed by, I'm employed by my patients. I'm no longer employed by insurance companies, which is quite a freedom.
It's nice to be able to answer to the patients instead of administrators.
Yeah.
Well, so just furthering that a little bit, a lot of people that are watching right now, in fact, myself included, I don't have a lot of experience with direct primary care, and so aside from a couple of the things that you just mentioned, what do direct primary care physicians offer that regular doctors don't?
Access, access, and access. So I do not claim to be better than other doctors who are still, as we say, plugged into the system. I'm not. I have excellent colleagues and friends who are practicing within the system, and I mean, they're outstanding doctors, and I respect them deeply, and I grew up around them and in that model myself, and that's the thing is that they're just covered under layers of just administrative bureaucracy, and it's just it would be hard to find a patient out there who has not at some point in time experienced the the 2-hour waiting room or the 20 layers of phone tree in order to get through to actually speaking with a doctor on the phone, or after hours trying to get even just the on-call doctor and having to pass through the answering service and then
Sure.
another administrative and another maybe a nurse and then but all you want to do is ask the doctor a question, and then you get a doctor that doesn't know you, who has to stop and look you up. I've been that doctor. I've been the doctor in all of those settings, and I mean, just to be able to streamline that relationship so that a patient who can my patients text me directly, they email me directly, there's just nothing in between me and my patients, and that's the value that is that the patients can benefit from with a direct primary care relationship.
Is it fair to say it's a growing model? The DPC
It is
model?
growing. It is a small. It's a grassroots movement, and
Okay.
it really is. I mean, just to give you a sense of the scope, in Massachusetts, where we have a very dense medical population here. I'm probably one out of 15 or 20 doctors in the state that practice this way,
Wow.
and there's maybe about 700 practices nationwide, and
Okay.
less than 1,000 doctors nationwide practicing direct primary care. But it's absolutely growing. I mean, this is, when I say there's about 1,000 doctors right now, I mean, 2 or 3 years ago, we're looking at 200 or 300.
Okay.
So it's catching on,
Yeah.
largely because doctors who are practicing primary care within the system are experiencing that unsustainability of just it's like molasses trying to get done the work that we were trained to do with all of the the red tape, and that's just not what we decided we wanted when we became physicians.
Yeah.
And people are experiencing that. They want to practice medicine again. I went into direct primary care to reserve my right to practice medicine.
Well, and that leads me to the next question. That was perfect. Is there an inherent problem with the current allopathic or Western medicine model?
I mean, it's just that there's too much of it. I mean, there's,
Okay.
we have what we call a healthcare system, and it's just way too much system and very little health. So everything in between, the care part of it
Yeah.
has just gotten so complex, and it's, there's just too many moving parts that it just completely disintegrates when
Yeah.
it comes to trying to actually promote the notion of health. And that's there's just that's like an endless discussion. I mean, tell me which direction you want to go, because
Well,
the answer is yes.
Yeah, right. And there's so many fingers in the pie, and we've talked about this before. One of the things that I guess third-party reimbursement is a big one we've talked about. Just getting people maybe to understand some of the different, like where that, like what is behind, like why is their healthcare so expensive? Maybe that's a way to start, and comparing the two models, because I guess what I'd say first of all is, why is healthcare getting so expensive? I think that's a question that probably everybody sitting at home wants to know.
Well, the thing it has is that there's been so many pieces added on to the structure of how healthcare is delivered, and I think a lot of it can be, it's challenging to summarize it, but I would probably say there's just too many parts to the delivery system of healthcare. So healthcare
Okay.
delivery has just become very complex, and just if you think about all of the, if you call
Yeah.
your doctor and you want to reach somebody, there's all these pieces in place, all these people that are sort of in the mix. You'll reach a secretary who will patch you through to a medical assistant, who will transfer you to a nurse, all before speaking to the doctor. Now those people have their roles, but the thing is, the more people that you add on, then the more salaries there are to pay. So this is just an example. Now for one sort of ancillary staff member that will never have a role in a practice like mine is a biller or a coder. So the thing is, in order to just process the payment system the way that it has been structured, you have to create these whole structures of personnel to interpret the coding and to kind of match it up with a different dollar assignment, whether it's Blue Cross Blue Shield, whether it's Medicare. So you need like people to the point that there's entire organizations that are dedicated to interpreting all of those variations in the payment structure, just to, in theory, to pay for a doctor visit. So if you show up at the desk, you don't, even if you give them a $20 copay, that copay does not pay for the doctor. It goes through about 30 layers of hands before becoming the dollar that is delivered at the salary level to a doctor or a nurse. And all of those layers, there's it needs to be paid for in order for it to exist. So there's too many layers. If you remove some of those layers, then it wouldn't cost as much. And over the course of time, there have been just multiple restructurings, whether it's at the hospital level or at a diagnostic center. That everything has been readjusted, and then it's a morass. So
yeah. Could you speak a little bit to the maybe choices that doctors make as far as like a lot of people will say, oh, those tests are getting so expensive, and is there an approach one doctor might take over another that speaks to expense?
That's a fascinating question. I mean, I think we all would like to believe that that we as doctors, or patients thinking of doctors, is that we only make our decisions based on what will be the most beneficial for the patient. But nowadays, there's so much pressure from sort of administrative levels to shift our numbers in a certain direction. In other words, if we do XYZ testing, then that will be financially beneficial for our group or our company or our organization. Therefore, we should choose this testing, or we should choose this level of treatment approach, as much as possible because of the financial incentive. And so we try to think of ourselves as insurance blind, but we're not. As doctors, when within the group practice setting, this was my experience, that we would actually find ourselves, I would be handed a list and say, these are the Blue Cross Blue Shield patients, and because because our organization has this contract with, that particular insurance, we have to prioritize doing this test for this list of patients. So we're going to mobilize the staff to call that list to make sure they get that test done. So the incentives are not transparent.
Yeah.
And that is, that's disturbing on a number of levels. In theory, yeah, it's good patient care, but it's only good patient care for that group. Meanwhile, people who have Hojo, insurance, they kind of get, deprioritized, so to speak, which is actually, commonplace with like Medicaid patients. They'll often get deprioritized because, the reimbursement structure is so, it's so difficult and so challenging, and we can't get reimbursement from them, so we're not even going to bother. We're not even going to take care. So just those incentives are there. They are real, and it's very it's painful as a doctor to say, okay, well, I have to shift my attention towards these patients because that's I'm told that's where the money is.
Yeah. What should people know to help them make the best decisions for themselves and their families?
I think patients would do well to take as close a look to their healthcare expenditures over the course of a year as they can, because there's just no shortage of healthy individuals who maybe are on one or two medications, if that are paying $500 to $800 per person for an insurance policy when they only see the doctor. Their entire interface with the healthcare community is to see a doctor once or twice a year and to pick up their medications once or twice a month. And you're paying, if you add that up, that'll amount to, like $13,000 a year to pick up, to see the doctor once a year and to pick up medications, just for the doctor to literally spend 5 minutes with you. $13,000.
Yeah, no, that's ridiculous.
So that's, when you think about that, I mean, the question to ask yourself is, am I really doing myself a favor by utilizing this insurance company to cover my care? I think I wish everybody would just sort of listen to either the car insurance model or the restaurant model, and I've got a couple of those. I shared some of those examples with you. I'm not sure if you want me to dive into either of them or.
Yeah, if you feel it. I mean, what I remember. Can you give a brief overview of the story?
So I like to call upon car insurance, because that's something that many of us can relate to. When you when you want to solve the problem of getting from point A to point B, you don't tell yourself, okay, and you say, I'm tired of walking, I want to drive. We don't say, okay, well, since I want to drive, the first thing I do is call Amica or Geico or State Farm and ask them to help me solve the problem of trying to get there. You say, I'm going to buy a car, okay? And insurance is a secondary concern. And when I have the vehicle, which I choose according to my preferences, and I allocate my personal funds to get the car that suits me. In other words, I exercise my right of choice based on how I use my dollar. Then once I have my car, then I insure it. Now, generally, I'm going to endeavor to be a responsible driver. I know that I'm going to do that anyway. So since I know I'm going to take good care of my car, I'm going to do everything I can to prevent an accident, then I'm actually going to pay as little as possible for insurance, because I don't like paying money. I'm going to pay as little as possible for insurance, and low premium insurance tends to come with a high deductible. I understand and accept that. I'm not planning to use that deductible at all, because I'm not planning on having an accident. I assure myself of that by getting my tires rotated, by getting my oil changed, doing all the things that are proper maintenance so that the car does not break down on me when I least expect it. And if a stiff wind blows a dead tree onto my car, I'm ready because I have insurance, but that's so rare and so unexpected that if I have to pay the $2,000 deductible at the time that it happens, I'll say, well, at least I have insurance there. But I'm not planning on using that deductible, multiple times per month at all. And I don't pre-plan to pay into the deductible so that, hey, if that dead tree falls on my car in December, insurance is going to cover everything because the deductible is taken care of with my oil changes. We don't do that. We don't have that option. We cannot call upon insurance to pay for our oil changes and our tire rotations. If we did, it is filing an insurance claim. When you file an insurance claim, you're viewed as liability, and your insurance premiums will go up. So every time we use insurance to cover our routine care, it's filing a claim, and you're not technically viewed as a liability, but the way that it's registered is a similar fashion. There's higher utilization, therefore the insurance companies have to make up for that utilization by increasing their premiums, and that's what we're all feeling.
Isn't that partly what happened with employers trying to find ways to not insure people anymore? One, the rise in cost, but two, the specific drags on their, let's say they had 2 or 3 employees that were 6 or 7 figure, you know what I'm saying? Yeah, what is that total cost for their pool? And all of a sudden, no, you're a big liability because you have so many smoking employees, you have so many obese employees, so many, that kind of thing.
Well, I mean, insurance, insurance has to operate on its own as well, and the goal of insurance is that it's risk sharing, and the higher the risk pool, then insurance is going to have. That means that insurance is paying out frequently. Well, the insurance company as a business has to make money as well. So if it's constantly paying out, then it's going to have to draw in more money, and it has to do so through premiums. So that's why premiums are going up for everybody. It's because the risk pool has gotten so high because there's utilization of insurance where it probably doesn't need to be used in healthcare.
So, what are the obstacles to working with a direct primary care physician?
Knowledge, information. I think the only reason that there's the only reason patients aren't making use of direct primary care is they don't know about it or they don't understand it, and that's if I think the more people learn about how much value you can get for such a low dollar with respect to healthcare, then more people would catch on. One of the, in our area in particular, another barrier is that health insurance costs are so high that most people can't conceive of adding on what they would perceive as another cost, even though in the vast majority of cases, having a direct primary care doctor can actually lower their costs. Because part of our philosophy in direct primary care is to not only, when we say as physicians, we will do no harm, we also consider that as we will do no financial harm. So whatever costs a patient may incur for their care, even outside of the scope of our services, if you need a diagnostic test or labs or medications, that sort of thing, we actually put in the effort to make sure that whatever we recommend is cost effective for the patient. So overall, when you play out those costs over the course of a year, it costs less to have a low premium insurance, to have a direct primary care doctor, and to have the direct primary care provider actually guiding your out-of-pocket costs for services and medications or treatments that you might need, so that it generally, most of the time, it can still add up to less than whatever you would have paid for insurance and premiums alone.
Interesting. It'd be fun to see a lot of that math drawn out, because sometimes we just need that visual in front of us to go, wait, how can that be possible? But then you can see it if it's drawn out in front of you.
Yeah.
We have to keep HIPAA laws in mind and doing that kind of thing. Can you at least provide some examples of general examples for people so that they can see maybe direct primary care in action, so that kind of thing, some of the benefits?
Yeah, with pleasure. And I would never, use any identifiers for patients. So, but I have a couple of different. So it's just to give you a sense of the span of the types of patients that DPC can help. One of the straightforward one is a working person. So I have a patient who is a nurse, and I understand her level of intelligence with respect to her health.
Mm-hmm.
She called me and told me that she could feel a cold sore coming on, and she's had cold sores before. Nothing could be seen. There's nothing to observe or examine, but she knows what it feels like, and it's always responded to, to Valtrex. So, I trusted her, and I prescribed the Valtrex, and in 5 minutes from the beginning of the call till the time we hung up, I had already prescribed the medication and it was over and done with. Whereas I am very, I've had this experience multiple times over where people will call in and, will insist that they have to come in for an appointment, which means they have to, take time off of work, lose half a day's wages, sit in my waiting room or or will say, oh, you know what, I can't treat you without seeing you, and I'm booked up today and my colleagues are booked up today. You have to go to urgent care to get your cold sore. So that was, that was all circumvented, over and done. Cold sore was dealt with in a matter of minutes, and she didn't have to go through multiple layers. She didn't have to,
lose work over
she didn't have to wait for me to call back. Any of that. I was on the phone right away. Another, a bit more of a, kind of unique example that's a little bit more unique to direct primary care is that I get to do home visits, which is, otherwise sort of just a visage of the past. A lot of people are surprised that there are still doctors that do house calls, and just for example, I have one patient who is a resident of an assisted living center, and when I did her intake 1 week, and the following week I'd actually only seen her again. I saw her twice in a week. Her daughter went to visit her and called me because she was concerned. She's like, my mom doesn't seem quite right. I was wondering if you could come check her out. I was available. I was over there. It happened to be someplace that was very close to my office, so I was there in under 15 minutes. And the people at the desk were shocked. The nurse was shocked. The daughter was shocked. They're like, "How'd you get here so fast?" Turned out she was doing very poorly. I called the ambulance. I called the ER, gave the ER a heads up. I was there when the ambulance arrived to be able to give them the story of what was going on. And so she was shuttled off to the hospital. I visited her in the hospital. She was sent to rehab. I visited her in rehab. And now she's back at assisted living, and I saw her with the same evening that she arrived back there. Those are things that are within the scope of practice at direct primary care.
Yeah, that is amazing. I think that's what's it's in my lifetime. It's been so long since I've heard stories like that. I mean, I don't want to give away my age, but but really 60s and 70s, and I have older siblings as well, and I come from a medical family, and I remember hearing stories like that back when they were smoking in doctor's office, but that's been a long time since that happened. It's probably back when I was paying $20, $25 a month for insurance.
Long time ago.
Yeah, right. And so what do you foresee happening with direct primary care and how it fits with the current model?
There's a lot of activism that's going on to try and promote access to direct primary care, because believe it or not, there are certain barriers, because it's a periodic membership. So that it's a periodic fee in order to have a membership. So in some states, that's still viewed as, by definition, it's being defined as insurance. So, state by state, has to be able to make the declaration that, direct primary care is not the same as health insurance. I think we're right about there in Massachusetts. We're actually, the activism is actually, in place right now with myself, or I should say with a group of doctors that I'm a part of. That I'm not as active nearly as some of my colleagues who I'm very impressed with. I've got some, serious trailblazers that I'm following. But other things are that there's wording in some of the federal IRS codes that, kind of there's some slight barriers with respect to using certain funds for direct primary care. And so we're trying to open up all of that so that people can use health savings accounts for direct primary care.
Okay.
So the thing is, you can't. It's
oh, I didn't know that.
Yeah,
Okay.
it's because because of again federal IRS tax wording that prevents HSAs from being used for like these periodic expenses,
Wow.
so that the HSAs couldn't be used for gym memberships. God forbid somebody uses their HSA for something that'll make them healthy.
Oh, I see.
But
yeah.
without getting too political, the
Yeah,
bottom line is
yeah.
that there's bipartisan support in both the Senate and the House at the federal level, stating that wording needs to be shifted. I mean, it's really minor changes,
Yeah.
and the thing is, because it's so minor, the attention to it has been low because of the. But we've spoken with our senators and House's representatives, and there's very once they hear about it. It makes perfect sense. They take a look at the bill. They say this is very very straightforward, but it just hasn't been brought to vote yet.
Okay. Well, before we say goodbye, are there any other key points we missed or that you might want to reemphasize to help us better understand what we can do to make our health and our healthcare experiences better?
Well, if you'll allow me to do the restaurant sort of example, this is the one that I've heard that is I think is a poignant
Okay.
way of understanding where healthcare has gone. So the thing is, if you were invited into a restaurant and you were told you get to eat anything off of the menu, it doesn't matter.
I like that.
Yeah, you'd love that, right? You get to eat anything off of the menu, which is actually what happens anytime you go into a restaurant, right? But you're handed the menu and there's no prices, and we've seen that as well.
Okay.
Now, the restaurant tells you, don't worry, you can choose whatever you want and you'll get billed later, or a little more commonly, if we want to shift the mentality, you can eat whatever you want and your insurance will pay for it. So now you can, if you understand that another party is paying for it, then we'll be like, are you more inclined to choose the bowl of string beans or the filet mignon? Now, are you going to choose the sliced cantaloupe versus the ice cream sundae? So when you make your choices, we're going to be inclined, if there's no sense of what the price is, to choose whatever the highest quality is, thinking, well, there's no difference in cost, which is not the case. So now, if you were told instead that, well, insurance is going to, don't worry about insurance, you will have to pay for this, but you're going to get billed for it later, then you're going to probably ask for those costs. You want to see what the prices are. You want to at least ask about it. Now, if you were told, well, there's insurance is going to cover part of it. Your lunch insurance is going to cover part of your meal, and you're going to have to cover part of your meal. And the way that we're going to work that out is your entrance fee to the restaurant is going to be is only covering the entrance, but half of it is going to be applied to the first 22% of your entree, and then another 6% of your entrance fee can be applied to the dessert, but that's only if it covers the entrance fee plus this $25 deductible, and by the time you get all of that plowed at you, you're just like, you know what, I'm going to eat whatever and I'll deal with it later.
Yeah.
So that's what's going on, is people are assuming there's no cost to the care or it's gotten so complex that we've decided we can't understand it. And then we just say, well, I can't figure out what my costs are going to be, so I just, especially when you're in a situation where you don't have time to make a decision, when you're getting wheeled into an ER, you don't have time to figure out whether your deductible is going to cover it. Or whether how much of your deductible is going to, play a role, or how much co-insurance. You're just there, and now those costs have piled on and added up, and it's, we are all feeling it in the premiums. So the thing is, simplify your care.
Yeah.
That's the key, and what we're trying to do in direct primary care is not build upon this structure that's been put together with duct tape and Band-Aids. All right, it's we've got a skyscraper. It's about to come down of healthcare, and instead of trying to fix the building from the inside, knowing just how unsound the structure is, we're trying to create a new structure based on a foundation of price transparency. So it's a whole new concept, and I would just love to talk more with anybody who's curious.
Well, that makes sense, and I really want to thank you for sharing that, your knowledge, your experience about direct primary care. It's been fascinating, and it really has been an honor having you on the show.
It's been wonderful to be here. I can't thank you enough.
I'd like to thank Dr. Mary Medeiros of Thrive Adult Primary Care for being on the show today. We learned a lot from her, and very excited about the direct primary care. There's a lot more information online if you want to check that out. In future shows on Health Naturally, we have topics such as mold and environment, what it does to your health and how to treat it, laser therapy, chiropractic, acupuncture, and more. And my name's Paul Gerst. This has been Health Naturally. Thank you for watching.